Hello, this is the module on care of refugee and immigrant populations. My name is Colleen Laurence. I am an attending physician at Boston Medical Center and an assistant professor of emergency medicine at the Chobanian and Avedisian School of Medicine at Boston University. This module is going to focus on emergency care considerations for refugee and immigrant populations, principally in the U.S. Before we begin, my co-contributors and I have no conflicts of interest to declare. During this module, we're going to define displaced and immigrant populations, describe factors that increase individual risk exposure, focusing on those that influence migration journeys and experiences on arrival and destination countries. We're going to discuss how these vulnerabilities might contribute to barriers in care seeking, share considerations that we as providers and institutions should consider when caring for refugee and immigrant patients, and finally outline additional avenues for education and advocacy. At the end of the module, there will be a post-module assessment and an additional case study for review if desired. Before we dive into the nuances of caring for this population, let's discuss why we should care as EM physicians. And we'll start with a basic numbers approach. To start, 44.9 million individuals, or just under 14% of the U.S. population, identify as immigrants and lived in the U.S. in 2019. It is a very heterogeneous population. Many have very many unique assets, and many experience significant barriers navigating the U.S. healthcare system. One major barrier that they tend to experience is language. 46% of immigrants identify as individuals with a language preference other than English, and this could limit their ability to effectively communicate with clinicians and staff. And while 33% of immigrants ages 25% and up have a bachelor's degree or higher, which is actually similar to the US-born population, education level does vary depending on country of origin, which can then impact their employment opportunities as well as their ability to adapt to life in a new country. In the first months of 2022, for those who work internationally with displaced populations, more than 100 million individuals were displaced worldwide as a result of persecution, conflict, and human rights violations. This was an increase of 10.7 million people compared to 2021. Furthermore, an estimated 2/3 of displaced persons worldwide are from 5 countries alone: Syria, Venezuela, Afghanistan, South Sudan, and Myanmar. And the sub-Saharan African region hosts an estimated 20% of the global refugee population. As we begin our discussion, let's clarify some terms that were going to be used throughout the remainder of the presentation. First, an immigrant is someone who makes a conscious decision to leave their home and moves to a foreign country, intending to settle there for some period of time. Immigrants are theoretically free to return home, though the factors that prompted immigration may outweigh the risk and benefits of returning. A refugee is a person who has fled their country of origin and is unable or unwilling to return because of a well-founded fear of persecution, war, violence, and persecution due to their race, religion, nationality, or membership in a particular social or political group. Once a refugee flees their home, they must apply for refugee status with an official entity, such as a government or the United Nations Refugee Agency. This process can take years, on average 18 to 24 months, and while waiting, many applicants reside in refugee camps where they may be exposed to other risks. Refugees are not permitted to enter their destination country until their application has been accepted and they have been cleared for travel based on both security and medical screening. An asylum seeker is also someone who seeks international protection from dangers in their home country, very much like a refugee. However, asylum seekers typically apply for asylum after they arrive at their destination or at a port of entry. Everyone has a legal right to asylum, and the United States has a legal right to obligation to protect those who qualify for asylum. As we're going to discuss shortly, the asylum process can also take many years to complete. Finally, an internally displaced person is someone who leaves or flees their home but has not crossed an internationally recognized border, and so they may or may not be recognized by an official international entities. Right now, some of the greatest concentrations of internally displaced persons are in the Democratic Republic of Congo, Syria, Afghanistan, Yemen, and Colombia. So while these definitions are pretty basic, they have evolved throughout time. If we look at immigration and humanitarian law in the US, for example, we can see that the ability to immigrate, apply for citizenship, and qualify for certain rights often reflects political and social movements and undercurrents of the time. I'm going to review a few key moments in US immigration and humanitarian law history. There are additional notes below highlighted in yellow if you'd like to learn a little bit more. The first national law concerning immigration was the Naturalization Act of 1790. This stated that any free white person who had been in the US for at least 2 years could apply for citizenship. The requirements were adjusted over the next few years, reflecting biases against certain nationalities or to limit the influence of certain foreign-born nationals, depending on political fervor of the moment. But Black individuals remained ineligible until passage of the 14th Amendment. This demonstrates that immigration laws have the potential to reify racial biases and discrimination, a trend that continues today. The Immigration Act of 1917 again demonstrated biases against individuals from certain regions of the world. This created a barred zone that extended from the Middle East to Southeast Asia, from which no person could enter the US. It also established a literacy test as a bar for immigration and functionally preferenced individuals arriving from European countries and capped immigrants arriving from majority non-white nations. The quotas and restrictions of the 1920s remained in place until President Lyndon Johnson signed the Immigration and Nationality Act of 1965 into law. This eliminated the quota system and established the principles for immigration regulation that are enforced today. These tend to preference family reunification, employment, and refugees. In 1980, the Refugee Act was passed, establishing a legal basis for humanitarian admissions of refugees and asylum seekers to the United States. The act defined a refugee and established a precedent for the President and Congress to determine a set number of refugees to be accepted into the U.S. each fiscal year. Since this law has been passed, there have been a number of other important legislative as well as social movements related to immigration, including implementation of the temporary protected status for migrants in 1990, which allows migrants from certain countries with unsafe conditions to reside and legally work in the U.S., with most recent examples being extension of TPS protections to Ukrainian, Afghan, and Haitian migrants. In 2002, the Homeland Security Act was passed in response to the 9/11 terrorist attacks. This centralized decision-making power over immigration policy under one agency gave greater power to the executive branch to determine who enters and leaves the country and led to the creation of the U.S. Immigration and Customs Enforcement Agency, or ICE. In 2012, President Obama issued the Deferred Action for Childhood Arrivals, or DACA, executive order. This created renewable 2-year grants of protection from deportation, as well as work permits and identity documents for approximately 700,000 undocumented individuals who arrived in the country as children. Notably, DACA does not provide a pathway to citizenship for these individuals, and they remain ineligible for certain federal benefits, which include health insurance. During the Trump administration, recognition of immigrant rights in international human law has become increasingly precarious. In December 2018, the Migrant Protection Protocols, or Remain in Mexico policy, was implemented by the Department of Homeland Security. This forced 60,000 asylum seekers to return to Mexico for the duration of their immigration proceedings, often forcing them to live in unsafe conditions. Then, in March 2020, the Trump administration activated Title 42, which gives the president the right to exclude people from certain countries during public health emergencies. The Trump administration claimed that they were using Title 42 to help stop the spread of COVID in immigrant detention centers. However, many believe it was a premeditated measure to keep asylum seekers out of the country. The previous timeline highlights the ways in which immigrants arrive in the U.S. and how they can be shaped by historical precedent as well as politics. We're going to discuss what this process can look like for different types of migrants today. First, immigrants may arrive in the U.S. either with or without documentation. Those who are documented include those who are granted or become lawfully permanent residents, colloquially known as green card holders, people with visas, recognized victims of trafficking or domestic violence, refugees, and those with temporary protected status. Visa holders can further be delineated into immigrant and non-immigrant visas, diversity visas, and TNU visas, which are specific for victims of trafficking and domestic violence. The term undocumented includes those people who enter the U.S. without approved documentation, as well as those whose approved documentation is no longer valid. For example, somebody might arrive on a tourist visa or with a medical treatment visa and stay beyond the approved date. There remain routes to citizenship for individuals who are documented and those who are undocumented. However, as we're going to discuss in the next few slides, the process for applying for and being approved for legal status, much less citizenship, is complex, politically fraught, and can take a really long time, sometimes between 2 to 10 years. So we're going to focus now on the process for refugees and asylum seekers in the U.S. using the schematic by Human Rights First. As we discuss each group, think about how these designations influence their individuals' legal, financial, social support, and healthcare services and protections afforded to them, and how their care is paid for, how it affects how we might care for them. Starting at the very top, individuals are granted refugee status before arriving in the U.S. after they undergo health and legal screening and application process abroad. Resettlement agencies do help to establish a place to live along with basic furnishings, climate-appropriate clothing and food, and help refugees to attend initial health screenings. They also help to facilitate educational enrollment, employment training, job searches, and other social and language support. Refugees receive around 8 months of short-term health insurance called refugee medical assistance. After this, they may be eligible for children's health insurance programs if they're children, or insurance through their employment or through Medicaid, depending on the policies in the state where they live. Other refugees may access healthcare at their community-based or hospital-based clinic that provides specialized comprehensive care for refugees. And they may use the emergency department or other primary care means to address their health concerns. As such, it is helpful for ED physicians to consider referral to a primary care physician if a patient is not already connected. In the year 2020, 11,840 people were admitted to the U.S. as refugees, which is far below the ceiling number of 18,000, which was established by the Trump administration that year, which was already an unprecedented low compared to previous years. Moving on to asylum seekers, there are a few different asylum processes. The first I'm going to discuss is an affirmative asylum process in which a person travels to the U.S. with proper documentation such as a visa, and then petitions to stay through an asylum application process. These individuals can remain in the U.S. while their case is undergoing review and are not typically detained by the U.S. Immigration and Customs Enforcement. In certain cases, they may even be allowed to work. In 2020, the U.S. granted asylum affirmatively to 18% of applicants, or just under 17,000 individuals. Other individuals arrive without documentation and request asylum on arrival at the border. These individuals may be kept in detention centers where they undergo a credible fear interview with the U.S. Citizenship and Immigration Services to determine if they are eligible for protection under the Convention Against Torture before they undergo the remainder of the process. Finally, individuals undergo the defensive asylum process when they request asylum as a defense against removal from the U.S. These individuals may have been previously denied asylum by USCIS, apprehended without valid documentation, or caught by Customs and Border Control entering the country without documents. Immigration judges hear defensive asylum cases and determine if individuals are eligible for asylum or not. In 2020, the U.S. granted asylum defensively to 7.7% of people, or just around 14,565 individuals. The most important takeaway regarding all of these processes, which I admit can be confusing to understand, is that they are complicated and take a lot of time, on average, at least 2 to 10 years. And during this time, seekers may not have any legal protection or access to services. There are also many individuals who do not necessarily fall into these categories of refugee or asylum seekers, for example, stateless persons, seasonal migrants, and some human trafficking victims. As I mentioned in the preceding slide, legal status can affect individual access to healthcare coverage. Typically, refugees and recognized asylees and victims of trafficking and violence are the most likely to have healthcare coverage. For others, it depends on a number of factors, including their legal status, their age, the state where they currently reside, among others. This chart provides a brief summary of the healthcare insurance coverage available to different groups. In general, undocumented immigrants over the age of 18 only qualify technically for emergency care coverage. And most states do recognize workers' compensation, though this depends on the degree of enforcement and support that individuals have in reporting. Immigrant children are also often covered by either Medicaid or CHIP. The Biden administration is currently proposing to extend CHIP and Medicaid coverage to DACA recipients. However, as it stands, coverage is variable from state to state. Some immigrants also qualify for marketplace health coverage, such as refugees, asylees, over 14 with valid permits, or under 14 who have applications pending, victims of trafficking or domestic violence, those granted withholding or deferred deportation, lawful permanent residents, those with temporary protected status, and non-immigrant visa holders with worker or student visas. Individuals who are currently applying for some of these statuses also qualify. Thus far, only 29 states, the district, as well as the District of Columbia, have chosen to provide Medicaid coverage to lawfully residing children and pregnant women without a 5-year waiting period. So, thus far, we've discussed some of the structural elements that influence immigrant access to healthcare in the US, but it's also important to consider immigrants' migration stories, the factors that prompted them to leave their home in the first place, their experiences en route, and how these might affect patient health risk. Some people divide these migration factors into those that push people to migrate to a new country and those that pull people to a new country. For example, human rights violations, persecution, violence, armed conflict, natural disaster, and poverty are all factors that would push somebody to migrate. Conversely, economic and educational opportunities or family reunification may be factors that pull people to migrate. These different factors might translate to specific health risks for immigrants. For example, patients who experience the psychological and physical sequelae of torture, violence, and persecution, or the effects of displacement and unreliable access to safe water and sanitation, obviously have different health risks compared to those who choose to migrate with better resources and of their own choice. While push and pull factors are important to consider, the distinction between them can blur, and motives can change during immigration journeys. Consider the difference between extreme poverty pushing someone to migrate versus the economic opportunity pulling someone to migrate, or the ability to attend school without fear of violence or persecution due to one's sex versus educational opportunity. The difference is somewhat blurred. As such, we have to be cognizant that some push factors might be considered more worthy or understanding as a motive for immigration, which may be influenced by structural and societal factors like racism and nationalism. This can then affect how individuals or societies perceive the rights of immigrants to be present in the country. Ultimately, it's important to remember that social, political, and economic inequities are often major forces behind the phenomena of immigration. Understanding the systemic factors behind migration and the forces that go beyond individual choice help us to avoid falling into the bias of considering some individuals as more deserving or undeserving of services. Returning to our discussion of health risks and migration, these vulnerabilities can also accumulate during the migration process, from before migrants leave until after they arrive at their destination. Think about the different conditions before and during, how the different factors before and during migration could influence a person's health, and how you might include these considerations in your care of refugee and immigrant populations. For example, the extent to which immigrants are vaccinated, screened, diagnosed, and treated for certain medical conditions can have downstream effects on their health during and after migration. Let's look at this concept through the lens of Ukrainian and Rwandan refugees. At left is a picture of Ukrainian refugees entering Poland in the spring of 2022. Before the Russian invasion, most deaths in Ukraine were due to non-communicable diseases like cardiovascular disease, diabetes, and cancer. So this population already had a diagnosed chronic disease risk factors contributing to their morbidity and mortality throughout their migration process. There was also relatively high levels of multi-drug resistant tuberculosis, HIV, as well as viral hepatitis in Ukraine, and low vaccination rates prior to the Russian invasion. This then elevates the risk for both individuals with these conditions, as well as other individuals migrating with them who might be forced into crowded spaces. Compare this situation with the one at the right of the Kigeme refugee camp in Rwanda, where 17,000 refugees and internally displaced individuals live as they wait out protracted refugee screening processes. They share one health clinic, one women's center, and limited access to adequate, safe drinking water each day. Though these two refugee contexts are different, the risks that these refugees and other immigrants encounter in the course of their journeys may be similar. They include physical duress of the journey. Do they cross by land, by sea? Do they encounter heat or sun exposure, dehydration, exposure to dangerous animals or plants, insects, inconsistent food or water supply, and subsequent malnutrition? Are they encountering any dangers from other individuals in the form of physical or sexual violence and extortion? Do they have adequate shelter? And are their living conditions forcing them to live in crowded spaces where they might be exposed to increased infectious disease exposure? In the next two slides, I'm going to share different frameworks for how we can systematically and critically think about the vulnerabilities affecting immigrant populations. The first schematic is an amalgamation of different frameworks, but generally speaking, situates structural vulnerabilities as an overarching macro-level force, which is then reproduced in different forms as social vulnerabilities and individual vulnerabilities. Structural vulnerabilities consider how political, economic, and social hierarchies produce and pattern individual and community health and contribute to negative health outcomes. These hierarchies are perpetuated by institutions at the national, regional, and international level. This structural lens decreases the risk that we might have of misattributing certain vulnerabilities to individual groups or individuals themselves or to cultural differences. At the next level, social vulnerabilities is used to refer to some of the factors mentioned just now, like discrimination and exclusion, as well as other factors like access to education and language barriers. Finally, individual factors can increase risk or conversely exercise a protective effect depending on the context and the person. This level includes identifiers like age, gender, perceived or expressed race or ethnicity, sexual orientation, mental health, and access to resources, among others. This is an alternative model proposed by the International Organization for Migration. It is roughly based off of an ecological model of health. And in addition to the structural and individual factors that we discussed on the previous slide, it also recognizes that immigrants belong to households and families and communities, much like we all do, and these may confer either protective effects or pose additional risk. I'm going to pause here and discuss the language that I've been using thus far in the presentation and that you may hear in other presentations, specifically the term vulnerability. Vulnerability is often used in public health in medicine to describe those at a heightened risk of certain negative outcomes or with limited ability to respond to certain stressors. But labeling any one person or population as vulnerable risk implying powerlessness, victimhood, or a need for external intervention, and also limits consideration of certain structural and social factors that might be at play. It can also lead to increased discrimination and stigmatization if people or groups are reduced to one or two elements of their identity. So, both as you interpret the preceding slides as well as moving forward in the presentation and in your own work, please be conscious of how you use this term and think about other options such as increased risk and being explicit about what's causing the risk. Before we move on to our case study, I want to discuss the practical realities and challenges of accessing culturally responsive trauma-informed care by migrants. We've already discussed the variable levels of insurance coverage, which may determine whether people seek care at a free clinic, an emergency room, or at another facility. Often it's difficult to anticipate the cost of uncovered care, which may limit health seeking altogether. Next, they may have difficulty getting to a place where they can receive care. Perhaps they live far away or in a healthcare desert. The trip may be burdensome or costly, or they may have to figure out how to navigate a public public transport system or arrange private transportation. All of this can also take time, which can be difficult if it means stepping away from family or job responsibilities. And finally, immigrants may be fearful of healthcare seeking for different reasons. The U.S. healthcare system is intimidating to navigate even for U.S.-born citizens, and certain immigrant populations may be reticent to seek care due to recent public charge discussions, as well as concerns about registering in a system or concerns for care they may receive. These barriers have a greater impact on non-citizens who are, in general, are more likely to have no medical home or place for routine preventative care compared to citizens. And as a result, they may seek out routine and emergency care in the ED. There are also barriers that patients experience in the course of receiving care in the ED or in other settings. These might include inadequate use of language interpretation services, cultural nuances and expectations that can be difficult to explore, especially in a time-sensitive, chaotic environment of the ED, lack of familiarity with certain conditions or medications, and difficulty following up or filling prescriptions, among many other factors. Okay, at this point, we're going to move on to our case study and look at an example of how these different factors influence care for a patient we might see in the ED, both prior to their visit, during their ED course, and after discharge. So to set the scene, you're working a 7 a.m. shift at your level 2 trauma community ED. Around 7:30 a.m., a new patient is roomed with a chief complaint of hand injury. On opening the chart, you see that the patient has Spanish listed as his preferred language. The registration personnel confirms this as they pass you, exiting the room, and adds no insurance. When you walk in the room, the friend accompanying the patient offers to interpret for you. You thank them, but defer. It's a Saturday, so there's no in-person interpreter who are typically present during the weekdays, and so you have to use a phone interpreter. The patient is grimacing as you get the interpreter on the line, so you order an IM shot of fentanyl 50 mics while you're planning to do digital blocks. Your nurse administers the fentanyl, saying, "Fentanyl for Dolor," in a loud voice. You introduce yourself in basic Spanish as you wait for the interpreter. After a minute of music, followed by the sharing of patient information, allowing the interpreter to introduce themselves, you are able to begin. You learn that the patient is a 27-year-old right-hand dominant male who presents with a reported injury to his right index and middle finger, as well as a laceration to his right thumb, sustained after his hand was caught in a gear at work earlier this morning. His friend, who's with him, pulled the emergency stop lever. His hand is wrapped in gauze, but he's reporting significant pain to the volar and dorsal aspect of his right thumb and index fingers, and some pain to the volar aspect of his middle finger. His fingertips also feel numb. At this point, we're going to pause for a few seconds and consider the following questions. First, what factors might have influenced this patient's ability and/or decision to come to the ED for care? So during these pauses, I'm going to ask questions, and there will be included answers in the Power Deck slide that you can review. But I'd like you to think about your answer to these questions first. A second question to consider: what aspects of our emergency intake process might contribute to patient fear and/or distrust? So returning to the case, here are your focused exam findings. You have a +2 radial pulse bilaterally, lacerations to the volar aspect of the right thumb, index and middle fingers extending from the PIP to the pulp, and dorsally into the nail bed for the thumb and index finger. There's exposed bone, possible tendon on your index finger. He has limited range of motion at the PIP and DIP, as well as dusky discoloration of his fingers distally and diminished sensation. You, of course, get an X-ray, and this demonstrates a highly comminuted fracture of the right index finger extending proximally from the right DIP joint, with associated soft tissue swelling of the right index finger, as well as the right thumb and middle fingers. So we're not going to dive into the nitty-gritty medical management, but basically this is a significant hand injury with likely microvascular and possible tendon injury, and you're going to need some degree of specialist hand surgery consultation. So you're at a level 2 trauma center, and you have orthopedic generalists on call, but you do not have microvascular hand specialist. So basically, the next step is to transfer the patient to another hospital, an academic hospital, which we'll say is about 45 to 60 minutes away. So some questions again for you to think about as you would approach this patient. How would you explain the need to transfer to the patient? What questions do you anticipate the patient would have in response to this discussion? And what barriers might you encounter in attempting to transfer an undocumented patient without insurance? Okay, moving on to the case resolution. You elected to transport by BLS ambulance after discussing the process and need to transfer with the patient and his friend, and they're amenable. The patient is accepted for transfer at the academic facility 60 miles away. You perform digital blocks, irrigate, rebandage, administer antibiotics, and update their tetanus. You follow up on the patient a few days later and learn that they underwent an OR revision amputation at the DIP with tendon repair as well as closure of the other lacerations. They were discharged with plans to follow up in the orthopedic specialist clinic in 1 week and to remain non-weight bearing with their extremity wrapped till reevaluation. You estimate that this clinic is approximately 80 minutes away from where the patient lives. So we're going to pause for a final time and consider the following questions. What difficulties do you anticipate for the patient after discharge? And what precautions or additional measures might you or another provider take in light of these? If you would like to work through an additional case study independently, either now or at the end of the presentation, you can click on the picture icon at right in the slide deck. But rounding out our conversation, I'm going to discuss steps that you can take as an emergency physician or clinician and as a member of a department and institution to facilitate culturally responsive, equitable care for refugee and immigrant patients and options for further education and advocacy. So first, ask about preferred language and always use interpreters in all of your interactions. Not just your HPIs, but all follow-up reassessments and discharge. Many patients prefer in-person interpreters, but we know that that's not always possible. In your conversations and actions, reinforce the confidentiality of your relationship. This is especially important for patients who may be fearful or suspicious due to past trauma or concern for government involvement. Practice cultural humility, create a safe space for discussion, and seek to build trust with patients. This will impact not only your relationship with the patient, but their relationship with future clinicians as well. This is especially important for certain groups like trafficked persons or victims of violence who may have many touch points in the health system before they finally disclose such concerns. As you build a relationship, and if it is relevant to the patient's presentation or follow-up, you may consider asking about country of origin, migration history, or physical or mental trauma, but you should never document their legal status in your chart. And finally, continue to educate yourself about available local, national resources and immigrant rights. As a member of an emergency department and broader institution, consider adopting affirming signage or using social media platforms to welcome patients and combat fear. Ensure that there are protocols in place to protect immigrant patients should any ICE individuals enter the space. Work with social work, pharmacy, and community organizations, including federally qualified health centers, to maintain a list of updated resources and places where patients may be able to follow up or seek additional support. Facilitate and service training opportunities so that you can continually improve your knowledge of how to provide immigrant-informed care. And consider creating an ED or hospital refugee or immigrant patient advisory board so that your patients have avenues to organize and advocate for themselves. Finally, from a patient perspective, support your patients to learn about their own rights and resources that might be available to them. There are many patient rights cards that you can download online from different organizations with different translated materials that can help your patients to have a better sense of how to advocate for themselves. The suggestions on the previous slides were adapted from the Society for Academic Emergency Medicine's Immigration and Advocacy Toolkit, which is a really quick read and a great way to think about some general steps that you or your institution can take. In general, taking steps to learn more by reading is a great first step. There's a ton of gray literature and academic literature about immigrant health outcomes in the US and globally, and they often include suggestions for how we can improve our care approach, delivery, and advocacy, as well as allyship. The Health and Law Immigrant Solidarity Network is also a great resource. They have several modules that provide deep dives into different topics that we discussed briefly today. And we already have momentum and support from our two national advocacy and professional organizations, SAEM and the American College of Emergency Physicians. Finally, there's a ton of local, national, international organizations that are really excited to work with us as emergency physicians and need our help in advocacy, social, medical, and legal assistance. For example, Physicians for Human Rights offers regular training to conduct asylum medical screenings and will teach you how to write bond letters. If nothing else, we can always strive to be a culturally responsive and empowering advocate for our patients and in our own ED departments. My references, as well as the post-module assessment and additional case study, follow this. Thank you for your attention and for your future care of immigrant and refugee populations.